Colleagues, distinguished guests, and participants from around the world, welcome to today's enlightening webinar, where we delve into the dynamic realm of healthcare innovation. Our healthcare landscape is being reshaped by a multitude of digital interventions, from registries to health surveillance systems, from telehealth solutions to mobile applications. These innovations are revolutionizing how we approach reproductive, maternal, newborn, and child health. They offer us a profound opportunity to enhance access to care, optimize utilization, and foster coordination among diverse healthcare providers. Yet, as we navigate this exciting transformation, it's important to recognize the complexity that lie ahead. In low resource settings, within low middle income countries, challenges emerge in designing digital health technologies tailored to the unique context of each community. In fact, we are still in the process of understanding how these technologies function optimally and for whom in these diverse environments. Today's webinar is a beacon of knowledge dedicated to illuminating the immense potential of digital health technologies in the context of maternal and child health. Through compelling case studies, the sharing of best practices, and the wisdom garnered from real-world implementation, we aim to raise awareness about the myriad benefits these interventions offer. Before I start or introduce the first speaker, I have learned that our colleagues from IDRC will be participating in today's webinar. This presents an ideal moment for me to extend a warm invitation to Dr. Wissam El-Bey, the IDRC new Regional Director for the Middle East and North Africa, to introduce her. And first of all, big congratulations, the new position.
Thank you very much, Dr. Youssef. It's a pleasure to join you this morning and all distinguished scholars on the panel. It's actually, I'm very recent with IDRC. This is my second week still settling into Jordan and into my new position, but I look very much forward to hearing some of the outcomes of the research that you have done in collaboration with IDRC, and hopefully in the near future to also engage with you. Just to introduce myself, I'm a medical doctor by training and have a long working experience in development, focusing on health systems management and health system strengthening. And I would very much be interested in learning about the research products that you have actually taken. Thank you very much for giving me this introductory opportunity.
Thank you so much, and it's really great, a pleasure meeting you. And I also would like to invite Dr. Kamar from IDRC to provide an opening remark. Yes, Dr. Kamar.
Good afternoon, or good evening, or good morning, wherever in the world you are. My name is Kamar Mahmood, and I am with the International Development Research Center, IDRC, for over a decade now. It is a pleasure that we've been part of this amazing group of researchers and the research that was conducted that you will all hear today about the research results. Just to let you know about IDRC, for those of you who do not know, it's a research for development organization that has, which is a Canadian agency, federal agency that supports research in lower and middle income countries. In this particular region, we are with one of the 5 program divisions that we have. Mine is a global health division, which was the funder for most of the research that is being talked about today. We've been present, our office, I think, in the Middle East and North Africa region has been here for several decades, but for the last several decades, we weren't so active in supporting health programming in health in the region. And it really started in 2016 that we got back into the region, and we got like I think there are more actors and players in the region who know of IDRC now. Uh, but before that, it was somewhat there weren't really many people who or organizations that knew about the kind of research that we support, or the kind of agency, the funding agency that we are. So hopefully today, when you hear about these research from these different research partners, you'll get a sense of the kind of research that we are interested in and we are supporting. And I'm really glad to see that some of the people from the very start have been here, will be presenting today. So thank you so much, and we are all keenly looking forward to learning about the results of today's webinar. Thanks for organizing EMFNet and Jordan University of Science and Technology.
Thank you, Dr. Kamal. Thank you very much. Before we start, I'd like to remind you to use the question and answer feature in the webinar to ask any question. Now it's really my great pleasure to introduce the first speaker, Dr. Maysa Nimr. Dr. Maysa is an assistant professor of public health at Birzeit University, Ramallah in Palestine. She is an emerging leader. She's now the director of the Institute of Community and Public Health. And she's the director of the MPH program at Birzeit University. Her most recent research project include strengthening adolescent health information system in Palestine, women's health, and the aspects of data governance and human rights in digital health initiatives related to maternal and child health services. Yes, Dr. Maysa, please.
Thank you so much, Dr. Yusuf. I'm sharing the screen. Hello, everyone, and thank you so much for this opportunity. Today, I'll be talking about the state of digital health for reproductive, maternal, and child health in Palestine, drawing from our recent research project that was conducted in Palestine and Jordan in collaboration between Birzeit University, Jordan University of Science and Technology, Privacy International, and the University of Oslo, and under the support of the IDRC. So first of all, talking about the digital technology and healthcare sector, which has widely accelerated all over the world, with diverse digital interventions being introduced in reproductive, maternal, newborn, and child health services, including registries, health surveillance systems, telehealth, and mobile applications. In some cases, these interventions have played a role in improving the utilization and access to health services and in strengthening the coordination between different service providers. These initiatives have helped expand the coverage of health services and overcome the geographical, social, and behavioral barriers, exemplifying their positive potential for enhancing the reproductive, maternal, and child health service delivery. And in Palestine, like many other countries in the world and in the region, there has been a gradual transformation into digital health solutions to improve healthcare access, delivery, and outcomes. And in general, the healthcare system in Palestine is now on its way to completely converting into a digitalized system, with several reproductive, maternal, and child health digital initiatives. So during our latest research and through a mapping exercise, we identified the main digital health interventions that are being deployed in Palestine, focusing on reproductive, maternal, and child health initiatives. And these initiatives, talking about Palestine, they included several categories, including the health information systems, including the Vicina system, which is the health information system being used in the governmental hospitals, and also the e-health system used by the UNRWA. And then we have the registries, including the Maternal and Child Health e-registry and the Mammogram e-registry. We also identified health surveillance systems, including the maternal mortality surveillance and the National Observatory for Gender-Based Violence. And talking about mobile applications and mHealth services, we identified two initiatives focusing on reproductive and maternal and child health services, which are the Nabd al-Hayat application, which is a private sector application, and also the EMCH application that was developed by the UNRWA, and I will talk about it later in some more details. So in this part of research that we conducted the mapping exercise, we mainly found that there is an increasing use of digital technology in the field of reproductive, maternal, and child health services, particularly expanding in recent years. This increase, however, is not accompanied by clear regulatory policies, especially when it comes to privacy and security of personal data and how this data is governed. So, talking about digital health initiatives, although they have the potential to promote effective and equitable access services, there should be a stronger regulatory mechanisms that are required in order to ensure the effective realization of this potential in practice. So during our mapping exercise, which helped us to identify and explore the characteristics of the available digital initiatives, we noticed that there is somehow an overwhelmingly rise in short-lived implementation and a vast diversity of digital tools with a limited understanding of their impact on health systems, human rights, data privacy, and security, and also the patient's health. So, given the complex goal of digital health solutions, we should have some kind of assessment in order to understand the maturity frameworks and approaches to assess the progress across diverse providers and settings, which we identified that it is highly needed. Therefore, in this part of our project, we aim to understand the maturity level of digital personal data initiatives for reproductive, maternal, and child health services within the fragile context of Palestine and Jordan. For that, we selected 3 digital health initiatives from Palestine and 2 in Jordan, and in order to measure the maturity. And one of the main outputs of this component of our research was the development of the maturity tool itself. So I'll talk about the maturity tool a little bit. So in this tool, we aim to assess the maturity using 3 main dimensions of the digital health initiatives: the digital maturity, governance and privacy, and the gender and the human rights. The methodological framework and the use tools were developed after an extensive process of disk search, literature reviews, consultations with experts in the field, and also pilot testing to make sure that the content is appropriate to the local context in both countries. So after exploring the different tools that already existed to assess the maturity level, we did not encounter one that met all of our needs and research objectives within this context. Therefore, we drew on a variety of the existing assessment tools and identified the key elements to integrate into our tool to enable the assessment of digital, reproductive, maternal, and child health initiatives in terms of maturity level. So talking a little bit about the findings of this part, particularly in Palestine, overall, the digital infrastructure and the technological readiness components were more advanced and showed higher maturity levels compared with the data governance and interoperability components. Specifically, talking about the 3 initiatives, the MCH e-registry initiative, maturity indicators were more advanced than both the Abyssina and the EMCH initiative. So now talking about the gender and the human rights considerations and why we decided to do this. So although the digital health has the potential and many benefits in utilizing many benefits when using it, using it without taking into consideration the possible risks related to security, privacy of the patients, and consequently their rights would yield negative consequences for potential beneficiaries. Therefore, in another component of our research, we aim to understand if and how gender equality and human rights are considered at various stages of the development and implementation of these digital initiatives, with a focus on the right to privacy. Within this setting, the fragile setting of Jordan and Palestine, in order to identify key areas of concern to be addressed through advocacy and future and further research. So in terms of this component, the use tool composed of three main components. The first focusing on the digital infrastructure, the second focusing on the considerations in digital initiatives, and the third one was more detailed checklist of human rights and gender equality considerations in digital reproductive, maternal, and child health initiatives, which contained planning, design, data and statistics, specialized knowledge and capacities, and management and implementation. So I'll talk a little bit about the findings, which is still in processing in the writing. So in general, the results show that there is a lack of systemic and comprehensive approach and consistency to how issues related to gender and human rights within the digital health initiatives are addressed, and how these considerations inform the design and implementation of such initiatives for the three initiatives that we addressed. Here are some of the identified challenges associated with the management of digital infrastructure for reproductive care and maternal health interventions in Palestine. These include first, the limited resources, talking about the availability of resources, including financial, technical, and human resources. These limited resources may pose challenges to the development, implementation, and maintenance of the digital health solutions, as we found that many of these interventions were based on external funds, and there are questions about their sustainability. Talking about infrastructure constraints, in certain areas, there is a limited access of reliable internet connectivity and electricity, which can hinder the widespread adoption of digital interventions, particularly in rural and remote locations. Privacy and security are still a problem because we need more regulatory frameworks, robust data protection policies, ensuring secure data transmission and storage, and addressing concerns about the data breaches or unauthorized access are important considerations. And the last one is the cultural and societal factors. We still have the problems with cultural beliefs, societal norms, and attitudes towards technology, which may influence the acceptance and utilization of digital health interventions. Sensitivity to cultural context and community engagement are crucial for the successful implementation. And here I thought I would briefly mention this part of the research in which we focused on the beneficiary's experience on a selected digital health intervention, which is the EMCH application. The EMCH application is the digital form of, or a digitalized form of the MCH handbook that was developed by the UNRWA in 2009, and it started to be used in Jordan and Palestine in 2017 and 2019, which is an interactive mobile application with an Arabic interface where mothers can enter their personal and child's data. Also, the application sends notification to mothers about appointment, information, and alerts, and it has an educational content about newborn and child care. In our research, we interviewed the mothers who use the EMCH handbook application. And in general, we found that these beneficiaries thought that the idea of having the application saved them time and effort, and it provided them with the support in terms of the health-related information and in reminding them of their clinic appointments and so on. However, we also found that women had limited knowledge on the privacy and protection of their personal data, and they were not informed about these issues when they started using the application. They generally had good perception and trust to the system and no concerns regarding the data privacy and protection, which actually raise concerns about how these initiatives should take into consideration the protection of beneficiaries' data and to increase awareness on this regard. Especially that we know from other parts of the research that some of these initiatives fall short in these aspects.
Yes, Dr. Mesa.
So finally, this is the last slide, implications that I can briefly talk about for advocacy and policy with the emergence of digital health initiatives that aim to enhance maternal and child health. It is crucial to address the different concerns through effective advocacy and policy, especially when talking about countries with fragile settings and with fragmented health system like in Palestine. One of the main needs that emerging from our findings is actually further advocacy and capacity building at all levels on the issues related to governance, protection of personal data, gender and human rights within the digital health initiatives. In addition to, we need advocacy initiatives to emphasize the importance of equitable participation of women in decision-making processes related to healthcare policies and digital health initiatives. It is crucial to engage with relevant stakeholders, including healthcare providers, policymakers, and civil society organizations to develop and enforce comprehensive policies that uphold human rights standards. In terms of data protection, the increasing reliance on digital health initiatives call for robust data protection measures. Policies should be enhanced to ensure the secure and responsible handling of health data, including personally identifiable information, strong encryption, access controls, and regular audits should all be implemented to safeguard against unauthorized access or breach. And finally, efficient governance structures are vital to ensure the successful implementation and sustainability of digital health initiatives. Thank you so much. I would like to thank MFNet for organizing this panel. I would like also to thank all my colleagues who participated in this research from Birzeit University, JUST, Privacy International, University of Oslo, and many thanks to IDRC for supporting this study. Thank you so much.
Thank you, Dr. Mesa. It is really very interesting presentation. Now I'd like to introduce the second speaker, Dr. Ziad Al-Khatib. Dr. Ziad, he is an associate professor in global health at Karolinska Institute. He is engaged in different projects related to research capacity building. His research covered different areas, non-communicable disease, communicable disease, and definitely mHealth. He is an eminent scientist because he published over 220 scientific papers and book chapters. He will talk about the children immunization app experiences from Jordan and Cameroon. Dr. Ziad.
Thank you so much, Dr. Yusuf. I will share my screen. Can you see my screen?
Yes.
Okay,
Yes.
wonderful. Thank you so much. So we all know about the importance of the role of children immunization programs around the world and how many deaths could be prevented annually from the vaccine preventable diseases. And in fact, now there is a big call from different organizations around the world that this drop that happened with the children immunization programs post-COVID. So we need to pick up the ball after COVID, but also we know how much it is very cost-effective as well, these programs. At the same time, we know that being a parent for children, that's a new life transition as well from the moment of pregnancy and after birth, that's for sure. So the idea of the children immunization app came out from all these different topics, from the topic of the vaccination for the parents to understand the value of the vaccines, why they are important, and also the reminders about the vaccination schedule. We are all familiar with this famous yellow card that is handwritten, and not all parents, they need to be really educated in the health field to remember all these little symbols of the vaccines. And definitely during COVID, with this whole era of misinformation and even disinformation, it became an issue that for parents to understand what is really true and false information being circulated. So all of this, we put it in an app called the Children Immunization app. And also, I will not even now, for the sake of time, I will not even dwell into how many SDGs that this topic of children immunization can fulfill. So the CIMA app, we first started this project by the collaboration with Dr. Youssef to do a testing or a pilot study in the Zaatari refugee camp in north of Jordan. For Rwanda, the parents, as an app that is being installed on the mobile phone for the clinics to be able to have a better programmatic monitoring for the vaccination. It's better when the app is being available as a platform for the clinic themselves. So this has been developed as a CIMA clinic app for Cameroon that is being now under pilot studied as we speak. And also in the pipeline now, Lebanon is following as well to be tested there. As an overview for the app, it helps the clinics to understand and have an overview of the children, how many children have been vaccinated, how many children have missed their vaccination, who is a defaulter, in which area is there is a visual map that the clinic staff can see. Do we see any pockets where the vaccination is actually being missed here or there? And also it can send an automated reminders to the parents in form of an SMS. So regardless if the parents are using a smartphone or a 2G generation phone, they can receive an SMS anyway. And also it sends cyclical health education messages as well to the parents for parenting skills. Also under development now, we are developing material for capacity building for nurses and community health workers regarding vaccination from a public health perspective. So then the staff as well, they get up-to-date information about the role of vaccines, and we will assess their level of knowledge prior the course and post the course. And this is also to have a holistic approach for the vaccination component. So this is just here for the sake of time. I try to make it very concise, just to show a visual overview. So then on a weekly basis in the clinics, they can see, okay, how was it this week? How many defaulters did we have? How many came on time? And also it can show easily using visual colors, that also to be able for the staff to help them in the details of the vaccines have been missed. And then we have a repertoire of health messages that have been tailed from the literature, mainly from UNICEF or the UNODC, regarding value of vaccines and regarding parenting skills. And then if they want to have in the clinic a report, this can be also done automatically. What is really important around this, the framework that is being used, that it's a participatory approach with the colleagues in the field, with the staff, and also the parents have been also involved along the way by having a participatory approach methodology. And by having participatory approach, then also sharing information and being transparent about the information and this project in these different contexts, it has developed a level of trust, because there is a lot of truthfulness in the approach. And by having this trust, then there is a sense of unity being developed between the clinic and the community. And we have seen this in Jordan, in Cameroon as well. We are witnessing this when there is this nice partnership happening between the clinic and the parents. So this can contribute to the progress and the development of this approach, that by using a digital tool, not for the sake of just technology, but also what is the vision behind it? What is the mindset behind it? What do we really want to achieve out of this? This is an overview of the different papers that have been published so far. And also I put a little QR code that you can, if you scan it, you'll be able to download all different papers. And also I have other work being done in the digital health field. You will be able to download all the work as well by just scanning this QR code. But of course, as an academician, there are students involved in these projects that through them we can learn together as well. And finally, this work couldn't have been done without the collaboration of different colleagues and institutions and donors as well. I mean, since we have the IDRC, the first funding started from Grand Challenges Canada was for the SEMA Jordan project. Thank you so much. Back to you, Dr. Yusuf.
Thank you, Dr. Ziad. Thank you. This is really brilliant presentation. Now I'd like to introduce the third speaker, Dr. Muhammad Al-Yahya. Dr. Muhammad is a professor at the Department of Health Management and Policy at the Faculty of Medicine in Jordan University of Science and Technology. Dr. Muhammad is currently a Secretary General of Jordan CDC. His research interests include leadership and management in healthcare, health systems, program and project management, change management, and health informatics. Dr. Muhammad, I know that you are facing some problem with your camera, but I hope that you will be able to share your presentation.
Thank you, Dr. Yusuf. Can you see my screen?
Yes, sir.
Yeah, thank you, Dr. Yusuf, and I would like to thank Infinite for this great opportunity to talk about a very brilliant idea in Jordan, which is Jordan stillbirth and the neonatal death surveillance system, which is JSANS. And I would like to thank IDRC and the Ministry of Health here in Jordan, Jordan University of Science and Technology, and UNICEF for their support to accomplish this work. So today I will talk about JSANS. Actually, our journey to develop a national surveillance system for neonatal deaths started in Jordan 10 years ago when professors started to work about neonatal deaths and perinatal deaths in Jordan. They did a prospective hospital-based cohort study. They included 18 hospitals with almost 22,000 women to work and to study neonatal and perinatal deaths in Jordan. So the findings were about the rate of stillbirth rate in Jordan was 11.6, neonatal mortality rate was about 15, and perinatal mortality rate was about 23.7. And at that time, that group of researchers start to think about how to develop a national surveillance system to start think how to avoid perinatal deaths. Neonatal mortality death in Jordan is 15 deaths per 1,000 live births. And then we start thinking about formative research to develop our surveillance system. We did formative research and we were thinking about the development of the surveillance system was guided by the findings of qualitative and quantitative studies conducted in 2018. A total of 80 healthcare professionals participated in 16 focus groups, included pediatricians, obstetric and gynecologists, senior residents, registered nurses, and midwives. The findings were that high rate of under-registration of neonatal deaths, almost we are talking about 85.54%, and no registration of stillbirth in Jordan at all. The death notification from including causes of death, is not usually completed by the physician. The death notification form does not include data about social determinants of death and related data to calculate equity indicators. And finally, physicians are not well trained on how to assign causes of deaths in standard forms. And we published this in a very high-ranked journal. Then we start to think about our own system. The proposed systems need to be user-friendly. The new system must replace all paperwork. Training sessions need to be conducted by the developers, creating a reward system to encourage staff to adhere to the proposed template. Make an access of the proposed system on both PCs and personal mobile phones for more convenient reporting, and make the proposed registration of neonatal deaths. And these ideas guided us to develop our own system. So in our formative research, healthcare professionals suggested to include reporting the cause of death for each death that occur in the hospital, establishing a committee which is an auditing committee or a focal point at each hospital to monitoring the implementation process of the new surveillance system. The system needs to be protected with high security measures and linking all hospitals in Jordan together electronically through the proposed system. Our system was developed as a secure online data entry system to collect, organize, analyze, and disseminate data on stillbirths, neonatal deaths, and their causes, of course, as a result of the formative research and previous studies.
Dr. Mohammed,
Yes.
please make it a full presentation mode, please.
I can't see the screen actually when I make it as a full. Yeah.
Okay, now it looks good for us.
Okay. So the uses of JSANT, measuring the burden of neonatal mortality, its causes and its trend, guiding the program to prevent and control perinatal mortality, prioritizing the allocation of health resources, immediate public health action, and formulating research hypotheses and providing a basis for research. So I'll talk about the system itself. In addition to stillbirth and the neonatal system, the system also registered births to use them as a denominator for mortality measure. And this is what we miss actually in Jordan, because we don't have a denominator. The system collects comprehensive individual level data on each death, allow for better adjustment of the crude mortality rate, allow detailed exploration of the causes of perinatal mortality in Jordan, calculate and report indicators, and make comparison between organizations. And we applied this system in 5 main hospitals in Jordan. Data flow and reporting, actually, in summary, the physician who attend the death should enter the data on the system in assistance with other healthcare professionals like midwives and nurses. Then they started to assign causes of death. Doctors are responsible for filling the causes of deaths using the ICD-10. The causes of deaths are set out as follows: main diseases or condition in fetus or infant, other diseases or condition in fetus or infant, main maternal diseases, and other maternal diseases. And actually, we developed our own website that guide the users and guide healthcare professionals, and we posted all new related news in this website. And this is the data entry screen of the system. Here we have a baby form. Actually, I'm not sure if you can see it or not, because
we see it, Dr. Mohammed.
So this is the baby form. So the healthcare professional should fill this baby form for each baby, okay, in the 5 hospitals. And as you can see, there are some of the data should be entered. It's compulsory. Some of them are optional. We try to minimize the time spent from healthcare professional to fill this baby form. We don't want to interrupt them. And in our system, we have other options. Like here, we have indicators. We can actually search, and we can use enter data, and we developed like it's not artificial intelligence, it's some kind of models that could help us to classify the deaths based on several indicators. For example, here we have basic statistics based on hospitals, mother occupation, mother educational level, governor rate, total monthly family income, mother age, gestational age, and so on. Another important option we have in our system, it's death rate by filter. So here you can filter, okay, and you can use all these indicators to filter on each death or in a group of death based on the basic indicators. And also you can search for specific death rates. Okay, here, for example, we have the fetal death rate. Okay, this is just an example. Neonatal mortality rate. So we have numerator, denominator, and the results here, death per 1,000. So just by one click, you can do, and you can explore all these indicators based on a group-specific death rate. Here we have like a categories for the cause of death, either disease related to fetus or infants or maternal diseases. Another main component that we have in JSAN system is Baby's matrix. We developed this Baby's matrix to help healthcare professionals to identify avoidable deaths. Here in this matrix, we have several colors. For each color, we have specific interventions that could be suggested to healthcare workers and that could help them to avoid such kind of deaths in the future. Actually, after we applied and we implemented this system in the five main hospitals, we tested the hospitals and we did like an evaluation from healthcare professional point of view. JSAND was tested by potential users in 4 maternity hospitals using online questionnaire. The respondents were requested to try JSAND by entering hypothetical data and test it. The results that almost 58% rated the language used in JSAND as clear to very clear. 61% reported that JSAND is easy to use, and 26% reported that JSAND is moderately easy to be used. The majority of respondents rated the user interface as easy to understand and the navigation through the system as easy. 95% rated the sequence of input data as somewhat clear to very clear. 83% rated the screen design and color as good to excellent. Almost all mentioned that the feedback one gets if wrong data are entered was moderately to extremely useful. Almost 83% were somewhat confident to completely confident with the privacy and confidentiality of the data, and JSAND was perceived as compliant with the used advice, either mobile, tablet, or PCs. In conclusion, JSAND is a valuable tool to completely register stillbirths and neonatal deaths and their causes. Potential user-rated JSAND attribute positively. JSAND can be scaled up to include data about maternal mortality and their causes, maternal morbidity, and other reproductive health problems. The potential for scaling up the system is very high for many reasons, including the simplified neonatal death review tools, easy process of reporting, and cost effectiveness of the system. And thank you.
Thank you, Dr. Muhammad. Thank you. It's another good presentation. Now, I'll introduce the fourth speaker, Dr. Marwiz Amiri. Dr. Marwiz, he's my colleague at Infinite. He's a research specialist at Infinite. His areas of interest include quantitative and qualitative research in health and nutrition, quality improvement in health, reproductive health, population dynamics, health in migration, and complex humanitarian emergencies, and health security and biorisk management. Dr. Marwiz.
Thank you very much for the nice introduction. I'll just share my screen. Does this look fine?
Yes, make it a presentation mode, please.
Okay.
Wonderful.
Okay. So my presentation is regarding another initiative that was funded by IDRC. This is called the Harmonized Reproductive Health Registry. And this is for the improving maternal and child health in Jordan. And I want to share Jordan's experience in this project. You will see an introduction and background to the issue, and then a brief on the project, the Harmonized Reproductive Health Registry. We will also talk a little bit about endpoint evaluation and the evidence obtained from this project and the way forward. And of course, you'll see the differences at the end. So for the introduction, with the overall aim to reduce maternal and infant mortality, the Harmonized Reproductive Health Registry, or HRHR, is actually a global initiative of WHO. And aim behind this is for improving data quality and data collection techniques in order to improve the maternal and child health. So this is a Harmonized Reproductive Health Registry. It's a global initiative. Lack of harmonization among different data collection platforms, it leads to enormous waste of resources. And also, on the other hand, it has the inability to compare and collaborate on across different data platforms. And also, poor data quality is another reason. All of this leads to a lot of misled and wasted efforts and initiatives. So that was the reason that we considered this project with the landscape of public health care in Jordan, like what you see in this slide. Predominantly, the MCH services are provided at comprehensive health centers, at primary health centers, and village health centers to some extent. And you see these are the number of health facilities: 109, 374 for the primary health care, and 186 for the village health. On average, each of these centers, they provide services to a population around 17,000 people in the catchment areas. So transitioning from paper-based data collection to electronic systems, usually irrespective of whatever project, it comes with challenges like lack of familiarity of staff. These are the couple of very important things. Staff are not familiar with those platforms, and we also need to develop appropriate capacity in order to effectively use them. In one assessment, we found that most of the CHCs were paper-based, and almost less than 1/4 of PHCs and roughly half of CHCs they were automated by Hakim. So this is the landscape of the country, of the whole country. While Hakim is a major health information platform, it's still the country faces low coverage. And the fact it's an electronic health record system, it's a health record system, it's not a registry. So the EHR solution is rather, it's a health record, it's for individual use, while registry is more for de-identified data, something that feeds into the system, and it's not for the specific individual use, but rather than beyond that for making decisions at bigger, wider level. So Now, I would like to provide a brief on the project very shortly. MFNet collaborated with the Ministry of Health and with relevant stakeholders to establish the Harmonized Reproductive Health Registry to improve MCH services. This was, in fact, an implementation research project, and we were looking at specific implementation variables in this project, like feasibility, scalability, adaptability, different variables. And it started in December 2017 until November 2021. So in fact, it lasted for 4 years. The new platform was designed, and all relevant stakeholders, including Hakim, were brought on board, and the new platform was successfully piloted in Mafraq Governorate of Jordan. Why Mafraq? Because it is the largest, the second largest population-wise, the second largest governorate in the country, and it also hosts the largest refugee camp in Jordan, the Zaatari camp. Also, it's the third largest governorate that hosts off-camp Syrian refugees. So, for different reasons, we considered Mafraq as the best candidate for the pilot of this. The project had 3 phases, and the preparatory phase, we conducted a situation analysis, as you see in this slide on the left side. We established a technical steering committee. It was on the national higher level, and we had some subcommittees, the reproductive health, the sexual and reproductive health SRH subcommittee, and the ICT, because it has 2 sides, the reproductive health and the ICT component. And we prepared for the next phase. The next was the implementation, and we worked on strengthening the coordination to improve quality of services, establish the electronic system itself, the platform, build the capacity of the staff to use this, and then we also worked on integrating gender into the indicators that we had. And then the final part of the project, it included midpoint and endpoint evaluation. Of course, monitoring and evaluation was all across the project, but we had midpoint and endpoint evaluation of the second or implementation phase, and also the dissemination of findings. So these are some of the pictures from this is a joint meeting of ICT and reproductive health working groups that were working on the project. This is another picture from Mafraq Governorate, which we had in our initial discussions, all the way from the initial discussions throughout the project. But this picture is from the initial discussions. And also this is during the work, and it shows on-the-job training for health facility staff on the platform, on the new platform. We also had the endpoint evaluation and followed by the technical steering committee meeting. The endpoint evaluation took place in October 2021. It got some highly positive results, because we're looking, as I mentioned, at the acceptability, usefulness, adaptability, appropriateness, feasibility, different variables of the project, the implementation, research, efficiency, sustainability, and scalability, including scalability, all of these variables. And we got highly positive scores, results on that. And in the technical steering committee, which was established at the beginning during their last meeting in November 2021, they concluded that the Harmonized Reproductive Health Registry, it's basically a web-based application. It has a great potential, and it can be expanded not only in scope, meaning additional to the current indicators, more indicators to be added, but also in geographical scale, the scale of the project to more governorates, because now the solution is in hand. We can replicate that easily to all, basically any health facility with mobile data can be connected to the whole network. So the technical steering committee actually highly recommended the HRHR, the Harmonized Reproductive Health Registry intervention, to be scaled to other governorates. Now, for the in order to evidence and to distribute or disseminate this evidence, we are considering a special issue publication titled "Evaluation of the Piloted Digital Reproductive Health Registry in Jordan to Improve MCH Services," and this actually is planned. We will be publishing this alongside other projects supported by IDRC. And then Ministry of Health recommends scaling this project, as I said, not only geographically, but also in scope. So we are considering this for 2024 and beyond. And the technical resources to use for this is, again, coming from IDRC, the scaling playbook, a practical guide for researchers. And this project was made possible through generous support of IDRC, International Development Research Center. Thank you. These are some references, and that's all. Thank you.
Thank you, Dr. Marwiz. This is really a very interesting project and digital initiative. Nice presentation. I'd like now to introduce the last speaker in this webinar. Sarah Sims is a policy officer at Privacy International. Sarah holds a BA bachelor degree in politics, and also she has a master degree in business and human rights from Queen's University Belfast. She currently manages Privacy International Health Project and lead on their work on maternal and reproductive rights work. Sarah has extensive experience working across a wide range of human rights issues, including reproductive rights, reparation of victims of the conflict in Northern Ireland, as well as investigatory experience in policing oversight. Yes, Sarah, please.
Thank you for the introduction. Sorry, I can't share my screen until the last speaker stops sharing their screen.
Dr. Marwiz, please stop sharing.
Yeah, actually, sorry for that.
No problem. Go ahead, Sarah. Now it's for you now.
Is that okay? You can see that?
Yes, go ahead.
Thank you, and good afternoon, everyone. Thanks for that introduction. So today I'm going to be speaking about Privacy International's methodology of taking a human rights-based approach to digital health and our work on reproductive rights. So Privacy International is an NGO based in London, but we work internationally with a global network of partners to advocate for legal and technological solutions to protect people and their data from exploitation. So why are we looking at digital health? So recently we've seen digital health systems alongside digital identity systems emerging across the world, telemedicine and the use of AI within the health field, from supply chain management to insurance premiums. But there is limited consideration of the broader human rights implications, and in particular, the right to privacy beyond data protection compliance issues. The COVID-19 pandemic has propelled this discussion further, with an unprecedented deployment of digital health technologies rapidly within a short period of time. Whilst it's important to acknowledge these developments can contribute towards the realization of economic, social, and cultural rights, such as the right to health, these changes are raising issues not only about privacy and security and data protection, but also dignity and discrimination and equality issues. In the evolving data-intensive and exploitative ecosystem, too often governments and industry are seeing new opportunities to exercise power over individuals, from surveillance to income generation and market domination and control. Without careful consideration of the impact and the risk, the promises which are meant to come with this innovation and tech advancement may not be realised. In many cases, they create more harm than good. Bolstered by technological advances, the processing of personal data creates new opportunities to profile, target, manipulate, and data exploitive practices have seeped into the provision of healthcare services. Privacy International has documented the emergence of these tactics in the reproductive health sector, with the proliferation of data-intensive health applications and data sharing practices. Opaque, automated or data-based decision making raises unique concerns in instances where life-changing decisions are made, not just at a certain point in time, but throughout the process, from deciding treatment to monitoring of treatment over time. It's important to acknowledge from the outset that health data is qualified as sensitive personal health data or special category data. So this category of data tracks higher safeguards, including limitations on the permitted grounds for processing it. In general, categories of data identified as sensitive can be related to types of discrimination addressed in human rights instruments and constitutional protections enshrined, such as the right to non-discrimination, gender being one of these criteria. So when processing sensitive personal data, further conditions must be met. The situations in which the processing of sensitive personal data is permitted should be limited, and where consent is relied upon to justify the processing of this sensitive data, it is extremely important that it is explicit and meets all the consent requirements. That is, that it's informed, it's free and specific. But in the case of access to essential services and to human security, if that access is dependent on allowing data collection, then meaningful consent does not exist as consent not freely given. So basically, in terms of our work on sexual and reproductive rights, so the reason PI started to look and explore this work and the use of data technology in reproductive maternal healthcare sector is initially because there is a direct link between our mandate to fight for the right to privacy but also the enjoyment of reproductive rights. The right to privacy is one of the precedents used to establish access to reproductive rights. And the connection between these rights exists because laws and policies which impede upon individuals' rights to access sexual and reproductive health services may also interfere with an individual's right to privacy and to make autonomous decisions as it pertains to their health and fertility. It is this framing and approach which led us, along with our global partners in 2019 and 2020, to explore further the consequences of digitalization of health on individuals' privacy, and more specifically, these developments in access to reproductive and maternal care. Since then, we've been exploring extensive data collection and data sharing practices by period tracking apps, as well as other ways in which digital platforms risk being exploited to restrict access to or mislead individuals seeking reproductive health care. As we continue to explore these issues, we expanded to include digital tools and technologies being rolled out in the reproductive maternal care sector. So I'm basically going to give an overview of the research that we've specifically done into period tracking apps. So with the increase of the role of the private sector in providing health-related information, we've been exploring menstruation apps and providers of sexual reproductive health information and services. This has become increasingly popular for certain groups of individuals to manage their reproductive health care, as it can be seen as a taboo area, and it gives people autonomy over their decision. So basically, this was tech-based research using the Exodus privacy to triage. So this is a technical analysis actually designed by PI. So we set out to look at apps that we noticed were most popular in different parts of the world, and we decided to look at Maya, the Mia app, My Period Tracker, Ovulation Character, Period Tracker by GP, and Me Calendario. So the Period Tracker by GP International did not appear to share any data with Facebook, but the other apps we looked at, on the other hand, turned out to be a little more indiscreet. And basically, as we expose in the report, the Maya app in particular, at the time of the research was conducted, we believed to be doing extensive sharing of sensitive personal data with third parties, in particular Facebook. So basically on the next slide, you can see this is looking specifically at the Maya period tracking app. So this app has over 5 million downloads on Google Play. And it's basically the kind of app that wants you to share a lot of private health information with it. So you can see here, this is the interface of the app, and you can see the type of information it requests of its user. And these are health information that is really not necessary in terms of predicting, for example, when your next period is. You know, it's collated health information on your blood pressure, your like insomnia, sweating, just, yeah, a lot of personal health data. So we can see here, this is actually looking at what data is specifically, how the data breakdown is like shared and analyzed. So you can see here in the circle here that it actually shows, we found out it was sharing data with Facebook, but it was actually sharing at the time of which any of those symptoms were actually edited. So that was actually being directly shared. And you can see here the type of information that was shared of your health data. But when it comes to medical health data, it's not just concerned about your symptoms. They also want to know about, you know, your use of contraception, and that too is shared with Facebook. And basically, Maya's privacy policy says that no personal data is disclosed to advertisers, but it then states that users' personal data may be used to comply with our advertisers, which wishes by displaying their advertisement to that target audience. So they don't specify whether this involves health-related data. So basically, their privacy policy was, yeah, misleading. So as a result of PI's, so our research also highlighted that the menstruation apps we were looking at expose serious concerns when it comes to their compliance with the GDPR obligations. So that's the European data protection legislation, especially in regards to consent and transparency, because the average user probably doesn't know they're consenting to this data being shared, that it, you know, the transparency around this. So basically, these are an overview just of our findings. So it was sharing information with third parties before you even got to give consent. Your profile was then essentially being monetized. There was vague and generic privacy policies and limited transparency. But as a result of PI's research and advocacy on these 6 popular menstruation apps, 4 of them made changes in their data sharing practices or launched internal investigations. These changes positively impact on the privacy of more than 5 million people. So that's just one example. So basically, what is behind this is that basically what we need is a human rights-based approach, a framework to identify the problems and solutions. So taking a human rights-based approach is basically ensuring that there's participation, non-discrimination, empowerment, transparency, and accountability, taking a privacy lens and a gender and feminist approach as well. So what does this look like? So something we've observed, it's been confirmed by experts in the global public health sector, is that while some issues around equality and issues of access, for example, the digital divide, are discussed with regards to digital health and health in general, there is limited consideration for the right to privacy beyond data protection compliance issues. What is needed is a comprehensive human rights approach, which provides a lens through which to assess developing threats to which individuals are exposed to through the proliferation of digital health initiatives. And only by exploring broader human rights implications from the right to health to non-discrimination and privacy, amongst others, can we ensure that solutions proposed integrate the necessary safeguards and mitigation strategies to protect people and their rights. So undertaking human rights due diligence is important throughout the life cycle of the digital health initiative. This is from the design, the development, deployment, selling, the obtaining and operation of the digital health initiative. A key element of their human rights due diligence should be regular, comprehensive human rights impact assessments. This means that there is a legal and regulatory framework, clear rules of the game established, accountability mechanisms for governments, as well as the private sector, and that other non-state actors, such as international institutions, such as developmental humanitarian organizations, which could be involved in these initiatives as well.
Sarah, please, we need to finish because we have multiple questions. Yeah.
Sorry, finishing
Yes.
now. Basically, just last few points is establish an effective oversight of the role and responsibility of the private sector, providing accessible, fair redress mechanisms to individuals affected, and increasing understanding among the health sector of the implications of these digital solutions, in particular their limits and associated risks, and how they should inform decision-making from to the design, implementation, and monitoring. Thank you.
Thank you, Sarah. Thank you so much for this inspiring presentation. I'd like to thank all the speakers for these interesting presentations and for sharing their experiences, because I mentioned at the beginning that this webinar is dedicated to illuminating the immense potential of digital health technologies in the context of maternal and reproductive health. You know, sharing the best practices, the case studies. This is really very interesting, and started to see from the comment and the questions, you know, I see that Dorba she's a registered nurse from Nigeria, is interested to join the team. So this is the idea of this webinar, is to let the colleagues from the region to be aware of digital initiatives. These are not the only initiatives, but unfortunately the duration of the webinar is almost 1 hour. It's difficult to cover other initiatives, but maybe in the future webinars we might cover, also introduce you to very promising initiatives in digital health and artificial intelligence. Before I take a question from the participants, I need to ask a question for Dr. Marwiz Amiri. I see that your initiative is really very promising in solving many problems in the country and even many countries of the region. What's the potential, Dr. Marwiz, for scaling up this initiative?
Thank you, Dr. Yusuf. Actually, as we looked at the platform, it's just linked with, and it's called the CPR slide. I did not go into these details in the presentation, but it's the we already have a computerized record system which is called CPRS, and it's located within Hakim system for all health facilities. But this is a CPR slide. It can be linked to any digital device, any handheld device or mobile. And the beauty of that is it can be easily replicated to all governorates. A similar thing can be copied or replicated to other countries. If they have already established systems that are good, maybe we still work on the Hakim systems. We added some indicators, we proposed some new ones, but the main platform is linked just to mobile devices, and that's it. It will be linked to wherever across the country, any governorate, it can work. So the same idea can be replicated to any country in the region.
Thank you, Dr. Marwiz. Thank you. I have a question from Dr. Fawzia Hanif. The question is already addressed, but I'm asking Dr. Mesa to answer it, you know, in public. Dr. Fawzia is the Deputy Director from Health Ministry in Pakistan. She's asking you about laws and regulation that have been made by your country to secure and save the patient data.
Thank you so much. Thank you for the question to Dr. Fawzia. Actually, throughout our research, we assessed and investigated the issue of the available policies and regulations that are related to data security and data protection in the country. And we also conducted a policy analysis exercise to analyze the available policies that are related to this issue. And we found that there are actually some data protection and data security laws that are very general and somehow old, and there are no specific regulations that could be adapted to the new digital technology and digital health specifically. And so for the new digital health initiatives that are being implemented, some of them have developed their own regulations and policies, but not all of them. And in many of them, they still struggle with this issue that there are no clear regulations, and that the general laws are not actually translated into practical regulations that could be used and could be suitable for the digital initiatives that are being implemented recently.
Thank you, Dr. Mesa. It seems that there is an interest also in JSONs that people want to know more. I have a question from Dr. Najib Shorbaji. He's a known figure in health informatics. He's asking about, is there a way to connect JSONs with Hakim to reduce data entry and reuse the data there? Hakim, by the way, is the health information system in Jordan. Not health information, medical record system, please. Yeah.
Thank you, Dr. Najib, for this question. Actually, JSON is a system by itself. So, yeah, we can integrate JSONs with other systems, and this is what we are working on now to see how we can integrate the maternal registration dates in Jordan with JSONs, but not with Hakim. Actually, to be honest, as what Dr. Yusuf said, Hakim is a medical record. It's an electronic medical records, and the system itself, it's not compatible with other systems. So when we start to think in developing JSONs, we were thinking how to make this system compatible with other systems. But now, no, it's not applicable to integrate it with Hakim.
I see. Thank you. I have a question to Dr. Ziad Al-Khatib. Dr. Islam Saeed, he's asking about why still there are some hesitances to make the health system digitalized. I don't know if there is still but the question, why there are some hesitances to make the health system digitalized?
Yes, it's a very good question. I also wonder why. Like, why, for example, we can see our banked data on an app on the phone, and no one really questioned the banking system, but we always question the healthcare system. I think it's maybe it's a taboo. I don't know. I think it's a matter of maybe traditionally we are used to the paperwork. But what I know from our experience with the SEMA, there is a trust in it from the staff and from the parents. When there is an explanation on the vision, what's the objective of this app and how is it used and how the data is stored and who has access to the data, there has been a strong sense of only about, I can also answer about other projects in public health surveillance where I have worked, but I think I would just limit it for now, but I will leave it for Dr. Yusuf or the colleague who asked the question if you'd like more explanation. Thank you.
Yeah, okay, thank you. Thank you. Sarah, you'd like to comment on this, because also I have a question for you. I see that there are some questions about the application of digital technology in remote areas, in refugee settings, and for women who are not educated. So how can we overcome these barriers?
Thank you. Yeah, well, I guess basically just it has to the advocacy has to kind of be directed at the companies if it's private sector applications, ensuring that they are taking a privacy by design approach, because the responsibility shouldn't be on the users. It should be that the applications are actually ensuring that human rights are protected from the actual design, because vulnerable individuals shouldn't have to worry about these things, especially considering their situation and they need access to healthcare, and those digital solutions are a way to access it. So it's about ensuring that government and companies are ensuring a human rights-based approach in the design of these applications.
Excellent, thank you. I still see that people are interested to know more about HR. So we have a question from Khadija Abu Khadr asking Dr. Marwiz Amiri, what are the components of maternal health that were included in the EHR, in HR?
Yeah, thank you for this question. I also saw, but I was not able to answer it. Just type the answer to all the questions. This is a good question. Actually, we have included, I don't have off top of my head all the components, but we have included all components of maternal and child health. We actually have a maternal card that is in Jordan used for mothers, and then we have a child card that is for the children. It's in Arabic, but what we used actually, we digitalized this card or the components of this card. All of them you can find in the platform. So I can be specifically answering with those indicators to the question that you raised, Khadija Abu Khadr. Thank you so much for that. Just regarding one thing, it's a general thing I wanted to mention it. We have the difference between medical records and registries. When it comes to privacy, and it goes back to between privacy and all these things, medical records, which has individual information, it should be somehow in a mechanism like end-to-end encryption, or that an individual can only access. But registries or whatever platforms that are used for wider health systems, they need to be looking at the aggregate data. So this is very important that we make this data available across platforms for the whole for the Ministry of Health or the whole country to decide, to make decisions and informed decisions and on evidence base. So we have for MCH all the data that are in the mother's form, maybe de-identified, and then fed back into the system so that we see the maternal and child health situation. Thank you.
Thank you. Thank you. I have a good question from Dr. Hiyam Al-Delki. She's asking, I guess, Mesa, does the EMCA covers mental health issues pertaining to children, adolescents, or mothers?
Actually, the EMCH application, if the question about it, it's, as I said, it's basically the digitalized form of the MCH Maternal and Child Health Handbook that was developed by the UNRWA for the Palestinian refugees. And this application contains different components related to maternal and child health, like antenatal and postnatal care, vaccination, and it has also different educational components that provide mothers with information regarding child care, regarding postnatal care, in addition to reminders related to the appointments in the clinics. So it has the different components, including also educational components related to also how to manage stress or depression or other kinds of mental health. So it has within its educational components, it has also this part.
Yeah, thank you, Dr. Mesa. Dr. Ziad, actually, I'm aware that your mobile application or the immunization app has been upgraded, or I don't know how to describe it, how it was used to provide psychosocial support during COVID-19. Would you please tell us about your experience about using this app during COVID-19? You are muted, Dr. Ziad.
I'm so sorry. My laptop got disconnected, so I connected now on the phone. Can you please repeat the question?
I will repeat the question. Sure. There was a question about using the mobile application or digital for providing psychosocial support or messages related mental health. I know from your experience that you was really very sharp and smart to upgrade your mobile application to provide psychosocial support during COVID-19. Comment in this, please.
Yes. So during this was started first in the Zaatari camp in Jordan, where we have seen an increase in mental health cases, and we published a paper on it. And based on that evidence, we updated the app by using evidence-based messages for the parents, which were provided from the UNODC, and they are a freely available material. So we updated the app in this way. And also the parents, they informed the staff that, you know, we have access to the internet, we have mobile phones, we can browse the internet, but we don't know what to trust anymore, but we trust the clinic, we trust the staff, we trust you. So then we updated the app by having an evidence-based health messages to the parents during stressful times such as COVID-19. And also there were volunteers from the community that they were kind of local champions who picked up the ball to even go and inform the parents because of the lockdowns, etc. So they took the initiative. And this was a very successful experience during this time. And based on that experience, in fact, now CIMA has always these information, like even now when it is CIMA clinic in Cameroon or like eventually in Lebanon, we kept this component, but then we capitalize on it because we realized that the parents, they need this information regardless if it's COVID or stressful times in general. So it became part of the package of CIMA.
I see.
Thank
I
you.
see. Thank you. I have multiple questions to Dr. Muhammad Al Yahya. Still, we have 5 minutes to address additional 2 questions. There is a question about why you only focus on perinatal health, not including maternal, the surveillance, for example. This is one question. The second question, what's about the baby's matrix? Did you see any improvement in the service while you are implementing the surveillance system? Yes, please.
Yeah, thank you. For the first question about maternal mortality, actually, JSAND is a pilot project, and we implemented it in 5 main hospitals. However, we can scale up this project to include data about maternal mortality and their causes. For example, maternal morbidity and other reproductive health problems. But meanwhile, it's just for perinatal deaths as a pilot project. But we are thinking in our scaling up plan to include maternal mortality, maybe in the future. Yeah,
it's good to mention also for a long time ago, Infinite actually is implementing a maternal surveillance system. Am I right, Dr. Marwiz? This is nice to mention some information, please.
Exactly. Yeah, that's right. We have the Jordan Maternal Mortality Surveillance and Response. It's a countrywide program. It was funded by USAID, and it was Infinite was in collaboration with Apt Associates. We implemented this program for the country, and that as a result of that program, we came up with the maternal mortality ratio for Jordan. So we have that component already, but we can always think of how we can bring all these pieces together so that they all are integrated within the health system. How best we can do that? Yeah,
this is really brilliant. You know, we have many questions about, but I'm trying to connect related question and summarize them. Dr. Marwiz, I'd like to ask you this question. We know that Infinite is highly interested in supporting the health system in the region by making this system more resilient, making the system directed toward achieving universal health coverage. And as you know that universal health coverage targets cannot be achieved without modernizing health system, without using innovative solution. So what's the future, or how digital health is promising to achieve universal health coverage and achieve resiliency in the health system?
I think now all the panelists will agree with me that now the trend is for the digitalization, and there is a need for a digital transformation, and it's not just exclusive to Jordan, but to anywhere. When we are thinking about the health system or any system, you name it, any sector. When we are thinking about a system, if we want to go from paper records or paper work to paperless, then the need for digitalization comes in. So there is a need for an overall digital transformation, and a strong document that can actually give a good picture of what should be done, what are the main components for this digital transformation. And it could be, I mean, health is a good example, but it could apply to any system. So when we think of the systems, digitalization of the systems, I think there is this very we badly need this for the digital transformation to happen. So I hope
yeah, you did actually. Thank you so much. Now we have come to the end of our webinar, so I would like to thank our speakers for their interesting and informative presentation. And I'd like to also thank our participants for attending today's webinar. I will take this opportunity again because I see that IDRC is a common funder of these projects and making big difference in the digital health in the region. Big thanks to IDRC for supporting such a project, and we hope that they support scaling up these initiatives. Thank you very much, and we hope to see you in our future webinars within the Infinite WEBi series. Bye-bye.
Thank you. Bye.
Bye.
Thank you.